Hello, everybody. My name is Elsie Kusel. I'm a paramedic with the Alameda County EMS agency, and I am an EMS coordinator. And most of my programs have to do with vulnerable populations and connecting the patients that we see on the 911 system with more appropriate services in the community. So the EMS system is actually about as old as the emergency room system. We got started about 50 years ago, before emergency rooms used to be detached from acute care hospitals, and they were sort of their own thing, sort of similar to what urgent cares are viewed at right now. So EMS started around the same time where with the advent of CPR and with understanding people were really getting hurt and dying from motor vehicle accidents, they started picking up patients with trained personnel, and at that time it was just first aid, and attaching them to the funeral homes, believe it or not, and to mechanic garages. So that's where we kind of get our start. So in the state of California, the EMS system, the emergency medical system, is regulated by the state authority. So that's the big circle on the top, the Emergency Medical Services Authority. Unlike other states in the country, because we're so large, they break us down into a number of local EMS agencies. So we essentially are doing the regulatory tasks of the authorities through our agency. And the thing with California is that we can individualize to meet the needs of the community. So Alameda County covers just that Alameda County. But in some counties that are smaller, there are EMS agencies that will cover the regulation and oversight of multiple counties. So what we do is we actually do share patient information. So we can share it with some healthcare and law enforcement and some social services. And on the same token, they can share with us, just depending upon, there are, just like all the other HIPAA things, there are some operational tasks and planning things and educational things that it's okay to share with us. So one thing to understand about EMS in general, there are in this county 2 levels of training. One is the EMT, which is the basic emergency medical technician training. You have basic first aid, CPR with AED, and we also are approved to give the auto injector epinephrine and Narcan, and of course use the AED like I said before. So that is one set of curriculum, and that's like a little bit, I think it's 200 hours of training. And then the paramedic curriculum, that's more like a year-long process, and we do advanced cardiac life support. We also have some trauma interventions that we do, and that's where you're seeing us do intubations and IVs and interosseous and other drugs that we give. So the thing about EMS is that all of the studies that we do are surrounded, or they involve emergency medicine, which is probably not the majority of the calls that we go on. So a lot of the calls that we respond to they might be urgent, but they really involve more of a chronic health issues. But the things that we get trained on are the heart attacks, the strokes, again, major trauma, seizures, these kind of things. So the thing about our curriculum, and it's standardized, not just in the state, it's also standardized in the country. They don't really go over in great detail about the conditions of chronic health. We have very limited education on mental health, substance use and addiction. And I am going to gather to say that there are no they don't cover the social determinants of health at all on the national curriculum. So because they don't really add that social aspect of health in there, we really don't have good information. Some EMS folks may have not even heard of the terms that I'm sure some of you will interact with in a daily way. So trauma-informed care, motivational interviewing, understanding the stages of change, and then having vetted de-escalation standardized techniques is also not something that is covered in the national curriculum. So again, we go back to our roots, and if any of you guys remember the show Emergency, and that's with these young blokes down in the bottom corner there with Johnny and Roy, that's where a lot of us understood what paramedicine was, and that was, you know, going to real emergencies. But like I said, we only go to about 4% of our calls are real, true blue emergencies, and everything else has to do with the other type of chronic health issues, mental health issues, behavioral health issues, and a lot of gaps that are addressed by social issues. So what we do in this county is we transport those who are placed on 5150 holds, which is a hold that's issued by law enforcement typically, and that means that that person is taking to a psychiatric emergency center. So the ones that we have in this county are children's, and I have the age groups there, John George and Willow Rock for the adolescent emergencies. If you're an older adult, you go straight to a medical emergency room, and you have to get clearance there. So what we found out a few years ago is that many times older adults that are placed on 5150s, because of this protocol, are taken to a medical emergency room, evaluated, and the 5150 is lifted from the patient. So very few times are they evaluated psychiatrically for whatever the problem is that they would have been placed on a 5150 in the first place. So back in 2018, we added oral Zyprexa, and I know that many of the behavioral health advocates were happy about the fact that we can give a pretty effective medication to folks who are just starting to have these feelings of anxieties, to help them kind of get under control and have a more effective visit to whatever psychiatric emergency room that we're going to. So 911 in general, next slide, 911 in general, we are starting to morph into something where we're connected more to health services. So not only do we perform the emergency medical stuff, we're also going to think more about emergency health issues. So assess and refer is a policy unique to Alameda County, where paramedics are able to assess the patient for any emergent medical needs. And if they're found to be pretty gosh darn stable, they can make a referral of that patient to a more appropriate service. So CAT, which Yolanda is going to talk about in a second, could be definitely one of those services. And other services that they can be connected to are older adult services. We have a partnership with Daybreak where they respond with a rapid response case manager, and they can really help some of these older adults avoid the emergency room by getting more of their needs met. We also are one of the test sites, pilot sites for community paramedicine, which helps again with the bridge between the patients that are seeing the 911 system quite frequently and connecting them with more appropriate services. We also are a huge part of the disaster preparedness and response. So the whole entire county health disaster preparedness and response is going to be seated pretty soon in our department, emergency medical services, so we'll have a better coordination throughout the community. So the brand new thing that started, I think, just last week is the community assessment and transport team. And I'm going to hand it now over to Yolanda Takahashi, who is my fellow EMS coordinator, and she can tell you, she's a manager of the program, and she can tell you more about it.
Yes, hi. So I'm Yolanda Takahashi. Like Elsie indicated, I'm the project manager for the CAT program, which we did start on the 20th. We started with the soft rollout of the program. So the CAT team, the Community Assessment Transport Team, it's a pilot program created in collaboration with Behavioral Health Services, Alameda Care Connect, Alameda County US Emergency Medical Agency, Bonita House, and also the County 911 provider, FELC. This model will assess those coping with behavioral health and substance abuse issues through an on-scene assessment and triage of resource needs rather than the traditional transport of clients that either go to emergency rooms or John George. The client being transported to John George or emergency department a lot of times don't meet the individual needs of our clients that are in crisis. So the goal is to refer our clients to a more appropriate level of care. And so this model is actually staffed with an emergency medical technician and a licensed clinician who will be able to provide behavioral health plans with a medical assessment if indicated, and a mental health assessment as well, and then provided either diversion, transport, referral, or 5150, 5585, which is for minors, or a transport to an emergency room. We can still do that as well on this, this team. So CAT, the way that the model works is they will be requested by officers on scene who will, normally they get dispatched by 911 for a behavioral health crisis. They will assess to ensure that the client is cooperative. The client shouldn't have any emergent medical issue or trauma that needs to have immediate medical treatment. And the other thing that's required is they need to be able to walk without assistance. If the officer requests CAT, they will actually come out and collaborate with the team. And after determining that the team and the officer are comfortable on the scene, the officer can actually return to their duties and they will turn over care of that client to our CAT team. So our CAT team will be able to do referrals based on their assessment. Our EMTs are actually being staffed by FELC, our current 911 provider, and our licensed clinicians are hired by the contractor who won the county contract. It's Bonita House, and they are actually staffing the team with the licensed clinicians. Both of these team members have received about, up to date, 109 hours of additional behavioral health training. Included in those 109 hours, they went through a 40 hours of training for crisis intervention that's held by Oakland PD. And this is the same training that officers currently receive to actually help assess with 5150s or anyone in a behavioral health crisis to see if they actually need to go to John George for advanced mental health care. So our teams, they will actually be working. You'll see, you may see them out there. They're working out of a Chevy Tahoe that's been modified for crew safety and for the client and for the team members. The vehicles are equipped with basic life support equipment to provide medical assessment. The vehicles also have the same radios as the ambulance provider, and they're being dispatched through our Alameda County Regional Emergency Communication Center, which we abbreviate and call ACRAC. And then last, our crews have access to this program called Community Health Record, which is where data is entered through multiple organizations to better share information among the providers and to help with coordination efforts in providing resource for our clients. So this community health record, and along with another program that we have in the county, is RadioNet. And RadioNet, we have a page on our RadioNet system that's currently used by our emergency departments. We created one for non-emergency providers, and it shows some of the organizations that have beds, like a crisis stabilization unit where or a sobering center where they actually have beds. Our team can look at that page and determine if a bed's available without having to call each individual place separately. So it helps facilitate the process that they go through to see what's the best disposition for the clients. So our CAT team can refer clients to, they will determine if they possibly can go to a doctor's mental health provider's office, a clinic, shelters, any type of crisis treatment facility, sobering centers. They can get APS and CPS services for our client if need be. And again, they can still go to the emergency room, John George, Willow Rock, or any other disposition determined appropriate and in the best interest by the CAT team for that client. So the actual vehicle is used to also transport these clients where they don't have the stigma of an ambulance pulling up and having to load somebody in an ambulance, and you have, the community, seeing that happen. So it's a little bit more lower key, where the vehicle is plain in description. We have a county logo on the side of it. It's just plain white in color. There's no light bar, so it doesn't look like a police vehicle or an ambulance. So, all those points are pretty great with this program. And then we just started our soft rollout. Like I mentioned, currently we have 3 teams that are staffed right now, Monday through Friday. They're on 8-hour shifts right now. We're staffed right now in Oakland, San Leandro, and Hayward. We will ultimately increase our hours, and we'll expand also to Fremont. And our goal is to actually get a total of 12 teams that'll be staffed and staggered in hours from the hours of 7 a.m. to 11 p.m. And it'll actually be 7 days a week once we get that full staffing. We plan on increasing our staffing every 3 to 4 months until we meet that goal of 12 teams. And then moving forward, we're going to continue to evaluate our CAT program on a regular basis, take into effect any data and input that we receive by all of our resources, including our teams and officers that respond to the scene initially. And we will share the updated information and updated schedules accordingly. So that's basically our CAT team in a nutshell. If anyone would like any pamphlets and related to our program, they can contact me, or any even additional information. You can contact me at my email address and request any additional information or pamphlets. Thank you.
Okay. So basically EMS is changing, as we should. We should, again, being an organization, a system, an industry, a profession that is 50 years old, we should definitely be updating with the times and with the needs of the community. So that being said, we also understand that, especially during these times of COVID, we're going to get stressed out of our minds, right? There's all kinds of different things going on, and the environment that we work in is unlike anything we've ever really experienced in the past. So we are connected to a program called Anticipate, Plan, and Deter, and we can go to that next. So this is available to all of you who are doing outreach work, you work in a clinic, whatever, and this is really to help you be a good care provider. So we're going to go to the next slide here. It's SciStart Responder. The URL is right there with the HTTPS, scistart.net/R2, which stands for Region 2. This program actually is trained to the healthcare workers who go out, and they were going to help with the Ebola response. So we have this program because, believe it or not, we got a grant to develop an Ebola response here in the Bay Area. And because of that, we have this. and it was customized to include more of a COVID theme. And so it's been really, really helpful, I think, for those of us who are working to just monitor ourselves so that we can stay healthy, not just physically, but also mentally. So there is I think they call that a QRC code. I'm learning this stuff as I go, by the way. So you can just use your QR reader and you can get up to that website. So this is the web page that you'll land on at first, and then you'll go over to the little blue box that says login. Let's go ahead, next slide. That blue box, correct, is up on the upper right-hand side. And it'll say, hey, you're new here, so you're gonna click on join us. And then the registration form, which is on the right side of the slide, is what you'll fill out. So under the discipline, that is a drop-down menu, and you do have the option of behavioral health, doctor, there's many other things. So make sure you put down your sponsoring agency, which would be the agency that you work for. You are in Alameda County. And then to get in, you need the registration code 67. So it's 777777. Okay, and then you'll register. And when you get to the registration page, you're going to see something. Let's see if you can go back one slide. It says using SciStart up underneath the logo that's on the left-hand side. It says using SciStart. So if you click on that, there's about 4 short videos of training of how to use the tool. And all I can say for myself, because I still work in the field, after I'm done with a shift or two, I'll put my input triage information, and it's amazing the things that you get exposed to that could really add up and cause some stress. And all it does is it validates the stuff and stressors that you've been exposed to so that you can employ your own resilience plan so that you can be a strong provider and a healthcare worker going forward. So if anybody has any questions about this program, I am more than happy to do a Zoom type of or Microsoft Teams type of training. Just contact me with your information, and it's only about 20 minutes to go through the whole thing. All right, so if there are any questions on any of the services that EMS does, please let us know. Again, specific to the CAT program and the community health record, please get a hold of Yolanda, and we are more than happy to share what we do with everybody. Thank you.
Thank you, Elsie. And can I just ask one question, which you may have answered in the presentation? So, you know, with COVID and everything going on, has that had any impact on your services or the way you are providing services? Or has everything pretty much the same?
So that's kind of a loaded question, right? Because our services are all over the map, right? In the very beginning of the pandemic and the initial shutdown or shelter-in-place orders, I can tell you that the system, the call volume was cut down, what, like half by 50% at least. So people were afraid to go to the emergency department. People were afraid to interact with strangers, even if they were emergency personnel, and avoiding going to the emergency department. And that's still true, by the way, but I don't know, maybe 2 months later, I think the beginning, let's see, March, April. So the beginning of May saw the 911 system call volume start to uptick. So people were calling, and it was really to just get sort of a house call or someone like a paramedic to check on them for a second and see whatever their needs are. And so the transport volume did not come back right away. But now here we are, I think in June, not only did we have the same normal call volume, it actually picked up quite a bit. I mean, I have my theories on that, because if people are holding their chronic health issues at home, not really addressing them because they're afraid to go to the doctor or go to the emergency room, then it seems to me that things will get worse while you're just sitting at home, right? So we're gonna see more people that we're calling. So that has been some of the changes. With the assess and refer program, the medic can find out who your medical home is and actually connect you with that medical home if they have the service, and sort of help schedule a telehealth type of appointment. And not just this type with the Zoom, but it could be just over the phone.
Okay. Thank you so much, Elsie and Yolanda. I think that wraps it up for us. So